So just to draw your attention to the key learning outcome for this subject, relates to 3C. So you're asked to use an evidence-based approach when undertaking orthotic management of a given patient. So I'm going to discuss the traditional and current theories relating to the effects of foot orthoses on lower limb biomechanics. But what I'm really going to focus on is the main learning outcome there in black, and that's using evidence-based information to understand how foot orthoses and footwear affect lower limb biomechanics. Okay, so just as an outline of today, I'm going to briefly talk about terminology and classifications of footwear and foot orthoses. I'll touch on these traditional theories of biomechanical effects, and then I'm going to talk briefly about biomechanical measurements, which include kinematic, kinetic, and muscular measurements. And really, I'm going to focus heavily on the best available evidence today. And if you've had a skim through your lecture notes, there's several systematic reviews presented, because as you know, that's the best available evidence that we can use. And then I'll give you a brief summary at the end. So what I'm hoping that you get out of today is I'm not going to present every little bit of evidence related to footwear and foot orthoses and the effects on biomechanics. Okay, we can't really do that. We probably need to really summarise it well. To be honest, we probably need 6 to 8 hours of lectures just on this topic to summarise it really, really well. So what I'd like to do is to give you the skills and understanding about what are the biomechanical measurements, which are the kinematic, kinetic, and muscular effects. They're the main ones. There are other biomechanical effects that you can look at. And I'll present the current best available evidence, but I can't present everything, every bit of evidence. Okay, so hopefully after today you'll go, well, I understand how you measure biomechanics. I can see what's been done and what's current evidence, and I can keep myself up to date now. Okay, every 12 months I can do a quick Medline search for new systematic reviews that are coming out related to footwear and foot orthoses. Okay, because that's really what you need to do. All right, because really in 3 months some of this information's going to be fairly redundant. Okay, so information's coming out really rapidly. Okay, so firstly, in terms of footwear is difficult to classify because there's all sorts. And if we got you to all take your shoes off today and put them on a bench up here, I think broadly you'd be able to put several designs in a particular group or classification, but there'd be several that you'd scratch your head and you wouldn't be quite sure how to classify it. And you might find that you're all wearing shoes today that have some overlapping features. Okay, so in terms of research and data, it's hard to classify shoes for footwear, and it's also what's particularly hard is to characterise the properties of shoes. So if you're going to do a research study using footwear, you can't just get a pair of shoes and say, well, we use these shoes, these Nike shoes and these Dunlop Volley shoes, and we did an experiment. You need to talk about the properties of the shoes, and you need to be able to say, this shoe is this sort of hardness, this shoe reacts in this way under force, and you need to be able to characterise those features. And doing that with footwear is really difficult. Okay, so one of the issues is heterogeneity, so the variation, the great variations in shoes is difficult. I've been involved in 2 systematic reviews related to the effect of footwear on lower limb biomechanics, and generally and broadly we've characterised shoes as occupational, so for example safety shoes, looks like there's a bracket missing there. Occupational shoes such as safety shoes, you can see those gum boots at the top of the screen, they're called clean room boots in some countries, so we've characterised them based on those. Athletic shoes, football boots, running shoes, ski boots, these are all the types of shoes that have been used in experiments. And what you will have noticed in the last decade is these toning or destabilising shoes have emerged and are really popular at the moment. And down the bottom there, that's an MBT shoe with the rounded curved sole. So hopefully you can appreciate that classifying and using universal terminology for footwear is really difficult, and therefore researching footwear is really difficult. In terms of foot orthoses, the APOD-A and American College of Foot and Ankle Orthopaedics and Medicine define this as an appliance to support, align, correct deformity or motion of parts of the body. And this is quite a dated what you might say, not classification, it's a definition of foot orthoses. And it's dated because we know that foot orthoses don't necessarily do those things. They don't necessarily align or correct deformity. Okay, so clearly you can see that applying definitions and terminology to these things are really difficult because of the issue below. So the varying materials and manufacturing processes. Okay, so if you've obviously now starting in the clinic, you've probably been into Lucy's filing cabinet and seen that there's quite a variety of prefabricated devices available now. They come in all different densities, colours, shapes, sizes. Some have wedging, some don't. So even a prefabricated device is really hard to classify as being a particular device and having a particular physical property. And of course, as podiatrists, what we do is we often add wedging to devices, and we immediately change the properties of a device, okay, to obviously address people's biomechanical abnormalities and correct their foot and change the way their foot functions. And we use heel lifts as well. Okay, so like footwear, foot orthoses are also difficult to classify because of the variety of manufacturing processes and materials available. Okay, so coming into today's lecture, you're probably thinking, well, how do foot orthoses and footwear interact with lower limb biomechanics? Okay, and by now I'd expect you've learned a little bit about root biomechanics. Is that correct? Yep. Okay, so you know that root biomechanics was all about aligning the forefoot with the rear foot and aligning the rear foot with the leg and making sure everything's perpendicular. And it's all about making sure that the subtalar joint functions around a neutral position so that the rear foot and forefoot are more stable. Okay, and therefore you could expect that under this root theory of biomechanics, if you were to prescribe an orthotic, the aim would be to achieve pretty much those 3 bullet points. Okay, and you would do that, if we take the first point as an example, align the rear foot and lower leg, we could do that by applying a medial wedge under the medial aspect of the heel, okay? Or we could have a bit of plastic from the orthotic curving up and meeting the subtalar joint to invert the rear foot. If we take the second bullet point, align the forefoot and the rear foot, we could do that by applying a forefoot wedge to the orthotic. Say if someone had a forefoot varus deformity, okay, then you could apply a forefoot varus wedge to the orthotic. And in terms of the third bullet point, subtalar joint neutral position, this could be achieved obviously by having an orthotic of some sort coming up and contouring the subtalar joint on the medial side and holding it in a position that you'd call a neutral position. Okay, hopefully you're aware that this theory of foot function and how the foot should function is problematic. Okay, and there's been several biomechanical studies that suggest that in fact the foot doesn't necessarily function like this at all. Pronation's important, and most of us don't actually return to a neutral subtalar joint position. Okay, so of course prescribing orthoses around this approach is also problematic. Okay, you're also aware of sagittal plane theory. Okay, so everything has to move in a sagittal plane freely, and you do this by facilitating the windlass mechanism, by facilitating ankle joint dorsiflexion and first ray plantar flexion, which is achieved through hallux dorsiflexion. Okay, and if you were to prescribe an orthosis to facilitate these mechanisms, there's all sorts of things that you can add to the orthotic to achieve this. Okay, you can do things like cutouts around the first ray. You might need to support the arch so that the first ray can plantar flex on the shell of the orthotic. There's all sorts of things you can do. Okay, so traditionally what we're trying to get to here is that if you go back 20 or 30 years and someone said, well, what do we need to do to make the foot work properly? This is what we do. Okay, this is what we need to change to make their foot function more effectively. And hopefully you've realised that what we think is probably the best model to carry forward, and we tend to do our teaching around this model, is the tissue stress model. So what we suggest you focus on when you're prescribing orthoses and you're thinking about altering biomechanics, is that you should be trying to reduce tissue stress to a tolerable level through rest, activity modification, footwear and/or foot orthoses. Okay, so try not to get too hung up about someone posting someone's foot to 23.9 degrees and that their subtalar joint has to be in this very precise neutral position, and their forefoot needs to be inverted 13 degrees so that it's parallel with their rear foot. What we're saying is let go of that sort of science, because we don't think there's really any evidence to support that approach. And what you focus on instead is trying to reduce tissue stress. So if someone's got problems with their tibialis posterior tendon, okay, what sort of force can you apply around the navicular to relieve stress in the tib post tendon without overloading perhaps their perineal tendons? Okay, so that's the sort of way that you need to start thinking in terms of orthotic prescription. Okay. All right, so that gives you a bit of an idea about how foot orthoses have been prescribed, but what you need to start thinking about is, so how do footwear and foot orthoses interact with the body and change the way the body is functioning? And when you look at all the literature, there's generally 3 measurement types that have been used to investigate this issue. And I know you're familiar with this from your biomechanics. You would have done some biomechanics in second year, a generic, yep. So this shouldn't be too unfamiliar to you. Yes, that on the right is a cadaver foot that's been placed in a sandal with lots of machinery attached to make it walk. And they do that. We don't do that at La Trobe. That picture's from Salford in the UK. Chris Nesto, who's a podiatrist. Okay, so the 3 approaches. The first is using kinematics to measure movement and position. The second is kinetics, which involves measurement of moments, forces, and plantar pressure measurements. Okay, which can be done via plantar pressure measurements, I should say. And then the third is measures of muscular activity, and this is done via electromyography and more recently muscle function MRI. Okay, so these are the main measurements. Of course, there are other ways you can assess the effect of footwear and foot orthoses on lower limb biomechanics. You can look at things like balance. You can, nowadays people are using the Nintendo Wii. Is it Nintendo Wii, or is it Sony? I'm showing my age a bit, I think. I have played it with my nephew. The bowling game's really good, isn't it? Nowadays, stuff like that's being used and validated for biomechanics research, okay, to measure things like balance, because it's really cheap. Okay, so these are the 3 approaches. So I'm going to talk about these 3 measurement types in the context of footwear and foot orthoses. Okay, so just a quick overview. So kinematics, as I said, assesses movement and position. This photo is taken from our lab here at La Trobe. You can see that this person's got a whole heap of reflective markers placed on their skin, and these markers have been placed in specific positions where they would provide some insight about movement of underlying bone. Okay, so they've been placed over particular bony landmarks to give us an estimation of movement of bone. And hopefully you can see through that and you think, oh, geez, that could be problematic, and I'll come back to that in a moment. So if we get this person to walk and we have these really expensive cameras watching them walk, then what we can do is we can render some really nice graphs showing how those markers are moving relative to the laboratory floor and relative to each other. Okay, so here's a classic one that you've probably seen before. This is the rear foot angle during a single gait cycle. So heel contact to ipsilateral contact, heel contact again. Okay, and you can see that the rear foot's starting in a position of inversion, rapidly inverts, remains fairly everted right through contact phase, and is still relatively everted into early swing phase. And here's a graph showing rear foot velocity. Okay, so what we can do, we can get this person to run with or walk in a particular pair of shoes, or with shoes with foot orthoses. Can't use the foot markers, obviously, because you can't put that foot in a shoe easily. So you can look at proximal measures. You can put them in a sandal, like the gory picture on the last screen. You can put them in a sandal with the markers poking out through the sides of the sandal, and then place an orthotic in there. Or you could wear different types of sandals with different midsole characteristics. But that's kinematic research. Now, I've just reshuffled some of these slides, so I apologise for that. I just thought they'd sit better here. Some of the limitations of kinematic research. Firstly, the use of 2D versus 3D measurements can result in parallax error. So pre-1990s, 1995, the research was really dominated with the use of two-dimensional measurements. So what that meant was that one of the body planes wasn't being captured, okay? And obviously we move in all three body planes. Our joints tend to move in three body planes with every movement. And if you're not capturing movement in all those planes, then you're not really measuring joint motion properly. So now most or nearly everyone uses three-dimensional measurements. Marker placement's an issue. When you're trying to estimate bone movement by placing markers on the skin, obviously it's a very rough estimate. And as you all know, your skin moves. If you just clench your fist, you know that your skin will move away from your joint. Okay, so kinematic research using skin-mounted markers is problematic. Okay. What we tend to see, this is a little bit premature, but what we tend to see with the kinematic research is that the changes with footwear and foot orthoses tend to be fairly small, and they're subject specific, and I'm going to come back to that later. The next measurement type are kinetics. So kinetics are a measure of forces, moments, planar pressures. These terms all mean a similar thing. We can measure forces with the use of a force plate. You can see this is a reconstruction of someone walking in a gate laboratory, and all the little pink dots are markers that have been placed on the person's body. They've got lots of pink markers placed on their foot, and the arrows shooting sideways and vertically and horizontally are ground reaction forces recorded from the force plate. Okay. So that's using that laboratory setup with the skin markers. If we just go across here, this is a picture of a in-shoe plantar pressure measuring device. So if you put a special plantar pressure measuring device in someone's shoe and get them to walk, you go back to your computer, this is what you see. You can see I think there's probably about a couple of hundred little square blocks here. And you can measure where their peak pressures are and changes in pressure with the use of different insoles. Okay, so you can pop this plantar pressure measuring device on top of their orthotic and then get them to walk, and then change the orthotic over and put it on a different type. And you can see how that's changing their plantar pressures. And this is a really nice area of research to get into. It's much cleaner than the other types. The third type, which involves measuring muscular activity through the use of electromyography and, as I said more recently, muscle function MRI. Firstly, with electromyography, this involves measurement of electrical activity of the muscle. It's usually measured in millivolts. The amplitude of a muscle contraction is somewhat related to the force of its output. It's not a direct perfect correlation, but it's certainly associated. So the larger the amplitude of the muscle contraction, the more force that it's producing. You can also assess the timing of activity or burst. So when is the muscle active during phase of the gait cycle? Does footwear and foot orthoses change when the muscle's active and when it's not active? So from EMG, we can imply changes in work or effort by the muscle. But as my PhD examiner from the UK so elegantly stated in his report, EMG is a bit of a black art. Okay, you can say that you're seeing all these wonderful changes in muscle activity, but unfortunately, it's very hard to say what those changes really mean. Okay, and I'll come back to that point. This is an example of an EMG tracing. This is from my work. This is actually for tibialis posterior. So what we've got here, if you just draw your eyes to this big black box here, what we've got is a single step for one person. Okay, so their heel hits the ground here, okay, 0, and then they've got forefoot contact. They go through mid-stance, propulsion, and then into swing phase, and then their heel hits the ground again around here. So this is a raw EMG signal. This is what it looks like when you're recording it on the computer. This is before it's processed. And then if we convert this all to positive values and we filter the signal, we get this nice smooth curve, which we call a linear envelope. And it's this curve that we actually do the analysis on. So you can see here that we can look at when that peak's occurring. Okay, look at that the vertical line here. We can say that it's occurring at 8%, and then we can put the person in a different pair of shoes and say, does that change when that burst occurs? We can also look at the amplitude on the vertical axis. So you can see this person's functioning at between, we'll just say 15 and 2, okay? It's a measurement of volts, millivolts. Okay, and we usually need to normalise an EMG signal. When you record the raw signal, you can't compare it to different people, okay? Because they might have lots of fat, okay, which attenuates the signal. So we need to normalise it, and usually we normalise it by getting them to do maximum contractions, okay? Get them to do a maximum contraction. We record their maximum activity, and then we can divide their gait activity by their maximum activity. EMG is also problematic. We can obtain a noisy signal, and you can get a noisy signal. A noisy signal is like when you're tuning your radio. You guys don't tune radios anymore, it's all digital. Gosh, finding it harder and harder to explain things. It's like tuning your television, you probably don't do that either. But you know what noise is. Noise is when you haven't got a clean signal, there's interference. And EMG is prone to interference. It can get interference from mains electricity in a room. It can get interference from oil and grease and electrolytes on your skin. There's all sorts of, it can get noise from your mobile phone. So you can end up with a fairly confounded signal. It's prone to crosstalk. So if you put a surface electrode on the skin, that electrode might be recording from 2 muscles, not 1. So that's obviously problematic if you think you're recording from 1 muscle. And there's all sorts of technologies to reduce that. And the last point there, to be very, very frank with you, it's unclear in many situations whether increasing or decreasing EMG activity, we can say, or EMG amplitude, is actually beneficial, okay, which is, it's quite unfortunate. It's quite clear in some cases. I mean, for example, if someone had some obvious level of spasticity in a muscle, obviously one of aim would be to reduce spasticity or reduce EMG amplitude in someone who might have neurological disease. But in healthy individuals who walk fairly normally, we're unclear whether increasing the amplitude of a muscle during gait is beneficial or whether decreasing it is beneficial. This is something that still needs to be teased out, okay? This research is still relatively new, you know. Current practices, it may have only been done for the last 15, 20 years. So we'll see lots of changes. And the last one there, the third way of analysing muscle activity is through the use of muscle function MRI. So what you can do is you can get someone to exercise, get them on a treadmill, put them in a pair of shoes or orthoses, and then after a couple of minutes, tell them to stop. You throw them in the MRI, you scan their leg, and what you can do is you can measure changes in the fluid uptake into a muscle. Obviously, when you exercise, your body sends more blood to your muscle, and the muscle hypertrophies and would have larger volume. Okay, and you can measure that with MRI. All right. So believe it or not, there's actually been a few studies that have compared changes in muscle volume wearing different shoes and different levels of wedging. Okay. That's what sorry, it's fairly low resolution, but that's what an MRI looks like. See, this is a particular muscle here. This is tib post. This is the muscle I spent 3 years of my life looking at. Really difficult to get to because it's right smack bang in the middle of the leg. So we stick wires into the muscle and avoid the nerves and arteries around the sides there. Okay, so let's get into it. So what I'm going to talk about first is some of the biomechanical effects of footwear. Now, again, we can't cover everything here. We could talk about high heel shoes, we could talk about ski boots, you know, we could talk all day about the biomechanical effects of footwear. But what I'd like to do is focus on a particular type of shoe and something that probably interests most of you, And you can apply this information to any type of shoe, okay? And obviously, you know, systematic reviews are coming out all the time. All the hard work's done for you. You can update yourself quite quickly. So to start with the effects of footwear, I'm going to talk about the effects on motion and impact force. Now, even when we talk about footwear, there's obviously all sorts of types of... Sorry, even when we talk about athletic footwear, there's all sorts we can talk about. But one that probably interests most people is motion control footwear, because motion control footwear has been around for quite a long time now. And most of you probably know that motion control footwear is a shoe that features a dual density midsole. So the density of EVA, or rubber, is denser on the medial side than it is on the lateral side, and it's thought that that would reduce foot pronation, okay, if I can put it very simply. Perhaps what's more topical at the moment and controversial is the differences between barefoot running and running in shoes, full stop. And again, it's a perfect example of something that you can go away and follow. You can follow the debate and you can follow systematic reviews that are coming in that area. But what I'm going to talk about today is motion control shoes. And the reason is because late last year there was probably one of the first or only systematic reviews published in this area by Roy Chung from Hong Kong. He's published a few studies on the biomechanical effects of footwear, and it's nice that someone finally got around to doing a systematic review on this area. So the effects of motion control footwear on running. So this is quite a nice, a really nice systematic review with meta-analysis. So they reviewed, they did their search, they found 500 potentially relevant studies, and through their exclusion found 14 studies that were included in the review, okay, with a quality score of at least 1 out of 5. Okay, so one of the first things you should be thinking about when we talk about motion control shoes is, do motion control shoes actually reduce pronation? And then you think, well, what's pronation? What are we really talking about? Is pronation movement of the subtalar joint? Is it eversion of the calcaneus? Is it internal tibial rotation? Is it plantar flexion of the first ray? These things really need defining, okay? Most people define pronation in terms of biomechanics as eversion of the calcaneus, because it's the easiest thing to measure. Measuring subtalar joint motion is really hard unless you stick pins into the talus and measure its movement. It's much easier to put a couple of markers on the back of the heel, okay, and measure that with cameras. So there's been several studies that have done this. You never thought you'd look at a forest plot again, didn't you, after doing IOP? You never thought we'd talk about heterogeneity or chi-squared tests or confidence intervals. Well, I keep warning you that that's not true. So here we've got a forest plot, and there's a few things you should be looking at here. So again, just to orientate, you've got our studies on the left here. We've got the sample size in the totals here. You can see that the meta-analysis included 75 experimental participants and 75 controls. Now, we're not talking about participants, sorry, we're talking about shoes. So 75 motion control shoes, if you like, and 75 control shoes. Now, the control shoe is likely to be a shoe that's got no dual density midsole. It's just a uniformly cushioned midsole, okay? But that varies. You can see that the confidence interval and the estimate of effect are listed here for the different studies. And when you eyeball that, you think, oh, they've all found that it favours the treatment, but most of the studies, the confidence interval crosses the vertical line, which would indicate no significant effect for these individual studies. You can see there's one study down here by Perry and LaFortune that found it does significantly favour motion control shoes. Now, when we talk about favour here, what are we talking about specifically? What does favour mean in this context? Pardon? No, not got the most results. So when we say favour, we mean that's a good finding. Favours the experiment. What are we actually meaning here? Excellent, that's right. So what we're saying is that the motion control shoe, if it favours the experiment in this context, we're saying that the motion control shoe reduces foot pronation. Okay? So you can see that there's only one study from all of these that found a significant effect when you look at the confidence interval And when you pull all of these studies and you do a meta-analysis, which obviously leads to an increase in sample size, all of a sudden we have this pooled estimate that's significant. You can see the confidence interval doesn't include 0. Okay, so what this says is that motion control footwear reduces pronation of the foot. That's what the meta-analysis shows. Okay, but it's a little bit concerning because, not to bore you to death, but there's significant heterogeneity here, which means the differences between the studies are significantly different. And you can see that because they're all over the place here. Okay?
Could those differences be in the type of controlling devices in the shoe?
It could be anything. It could be anything. It could be a dodgy honours student doing the data analysis that made a mistake. It could be they use different shoes, different sample sizes, all of these things, all of these factors, and we can't attribute it to any one of those because we don't know. Okay, so but the message is in the meta-analysis that they do have they do reduce foot pronation, which is, it's intuitive to think that, and that's what everyone's thought for many years, but no one's ever done meta-analysis and made a definitive conclusion. But you need to interpret that with some caution because of the differences in the study results, and essentially that's really hinging on this study here, okay, which is weighted 13% in terms of sample size. Okay, so just look, we don't expect you guys to be able to rattle off all of the aspects of meta-analysis again and this, but you should be able to recognise meta-analysis is really important, really good high-level evidence, and in this context, motion control shoes reduce foot pronation, which is really interesting. Okay, when we look at impact force, this is generally measured. Impact force is when you're running and your heel first hits the ground. That's the main impact force. There's also another reactive force when you push off, but generally when we talk about impact force, it's that first impact when you're running. You can see there's lots of studies that have investigated impact forces during with motion control shoes. And what you can see here is there's just a statistically significant effect that motion control shoes do reduce impact force, but only just. If you look at the confidence interval, this is actually, it's quite confusing. This is actually a percentage. This is 18% to, that's 1%. Okay, so you can see it's only just indicating a significant effect in reducing impact force. Okay, so that's the Chung study. So that's what we know about motion control shoes. Now I've cherry-picked the results here. I'm not presenting non-significant findings. They did do another analysis on internal tibial rotation and they found no significant effect. Okay. Okay, so in summary, motion control footwear was effective in reducing the amount of foot pronation and the peak vertical impact force during landing. However, there is no evidence that suggests motion control footwear controls kinematics of the proximal segment. So the proximal segments being tibial motion and, well, you could include knee motion, femoral motion, but that's a really neat finding. So in terms of footwear, you can apply this to any type of shoe, okay? And as I said, this is the first systematic review with meta-analysis. There aren't any others that I'm aware of. There's several systematic reviews related to footwear generally, and there's been a recent one on high-heeled shoes too, okay? And that slide's not in your notes. That's why everyone's distracted. Did you want to take a sec to write that down? Yeah, sorry guys, I just was walking out of my office and I thought I should add a summary slide for that. So it's just a summary of those two slides. Motion control footwear was effective in reducing the amount of foot pronation and peak vertical impact force during landing, but there's no evidence that suggests motion control footwear controls kinematics of the proximal segments. Now, I'm going to throw something at you, not to totally confuse you, but I want to be very transparent about what this all means, okay? So, does that mean that motion control footwear is beneficial? No. Does it mean that reducing pronation is beneficial? Does it mean reducing the impact force is beneficial? Are you less likely to get injured? Don't know. Don't know. Okay? These are biomechanical effects. All right, so just be really clear about that. I don't want you to leave today and go, oh, hooray, motion control footwear reduces foot pronation. That's a really good thing. We don't know if it's a good thing. We just know that that's what happens. We've been able to measure it and characterise it. Okay, so just be really clear about it.
So there's been no studies done to show that pronation leads to injury. There's been no
There's some evidence that a pronated foot type and some movements associated with pronation increase the risk of injury, but it's not definitive evidence, okay? And someone then hasn't gone and measured whether changing that fixes the problem, okay? So you can see where we're at with research. Got a long way to go still. That's all I'm going to say about footwear, okay? As I said, we can talk for 8 hours about footwear and all the biomechanical effects, but that gives you an idea of what you look at when you look at the literature, and you need to keep yourself up to date with it. In terms of the effect of foot orthoses, again, we can look at motion, impact force and muscle activity. And I'm actually going to present all three biomechanical measures for this section. Okay. Best available evidence, there's two systematic reviews and a book chapter or book I'd actually highly recommend. The first systematic review there was from Catherine Mills, who's a physio. She was doing her PhD at the AIS when she wrote this. And this is a really good systematic review because it actually covers kinetics, kinematics and EMG. Okay. Now, when someone says neuromuscular effects, which you'll see in a moment, they're talking about muscle. They're talking about EMG. Okay. Second systematic review is one that I published in 2009. Catherine's is better than mine because she did meta-analysis and she looked at kinematics, kinetics and EMG, whereas I just looked at muscle activity. Okay. The amusing thing, though, is that I actually peer-reviewed this when it got submitted for publication, and we actually presented our work at the same conference. And for some reason, my presentation got given a podium presentation, and hers was given a poster. And we thought that was hilarious and unjust because clearly her systematic review was better than mine. Anyway, the third one there that I highly recommend, if you're really interested in biomechanics and this stuff, I'd recommend buying this book. It's by Ben O'Nig. Ben O'Nig is the big wig. He's the man in biomechanics and foot orthoses. His research is based in Canada. He's probably the highest profile biomechanics footwear foot orthoses researcher in the world. Okay, he's been prolific, hundreds of publications. And he brought out a book, 2010, Biomechanics of Sports Shoes, but it's heavily focused on foot orthoses as well. So if you're looking to buy something, I'd highly recommend that. You don't need to buy it for this subject or follow this lecture, but it's something you might be interested in. Okay, so I just want to summarise Catherine Mills' systematic review. So foot orthosis and gait, systematic review and meta-analysis of literature pertaining to potential mechanisms. Okay, she reviewed 30,000 studies. Oh my goodness, how boring would that be? Okay, she didn't really. She would have just skimmed through the title and abstract. You can see that she found, in the end, 15 studies related to kinematics, 6 related to shock attenuation. What category can we put that in? Shock attenuation. Planar pressures, which is what? Kinetics, very good. Neuromotor, which is the electromyography category, muscle activity category. Okay, so again, I'm going to cherry pick the results here. I'm just highlighting significant findings from the meta-analyses. Now, I just want to orientate you here because it's going to look really confusing. So we've got a forest plot. You all know about forest plots. And what we've got here is we've got a solid black diamond and then we've got 2 clear diamonds. And the solid black diamond is the meta-analysis. And you can see that that's been pulled from the 2 studies below. So the Munderman and the Stakeoff study. When you pull those findings, that's the result you get for the meta-analysis. Okay? So we're starting off with kinematics, movement and position. And we can say that foot orthoses, if you look at the meta-analysis, I should orientate you to the horizontal axis, that's degrees. This is a reduction, and that's an increase, okay, to the right. You can see that foot orthoses reduce peak rear foot eversion, which again, it's quite intuitive, isn't it, to think that if you put something under the medial aspect of the foot, you're going to evert less. That's pretty easy to follow. What's perhaps more, to take a more sophisticated view of this though, if you pick it apart, obviously these studies have used all different types of foot orthoses and different features, okay? So in this case, when individuals are not injured, so there's no history of injury, and you use a posted, non-moulded device and compare it to a controlled device, which might be a sham or a flat insole that's placed in the shoe, we see a reduction in peak rear foot eversion. Okay? So posted, non-moulded. So there was no significant effects here. If you look at injured population, posted and moulded, we don't see any effects here. If we skim down here, tibial internal rotation. In those that weren't injured, again, the Munderman and Stakeoff study pulled together shows a significant effect, only just not crossing the vertical line here. You can see that foot orthoses reduce tibial internal rotation, which again is intuitive. So you put something under the medial aspect of the arch, it reduces the amount of internal rotation of the tibia, and up the top there, reduces peak rear foot eversion. Okay? There's all these non-significant findings though as well, which you can't ignore. And of course these findings are specific to very specific types of foot orthoses with very specific properties. Okay, and this is where it gets a little bit confusing when you're trying to interpret this literature. Okay, because we can't say that all flavours, sizes, shapes of foot orthoses reduce peak rear foot eversion. We can only really relate it to the types that were used in these studies. Okay, but you can see what's emerging here. We can see that the literature is supporting our basic ideas of how foot orthoses affect motion of the lower limb and foot. So what we saw there was a particular types of orthoses decrease peak rear foot eversion and tibial internal rotation in non-injured cohorts. Again, we saw small and subject-specific changes. When you look at the individual studies and you look at the way individual participants responded to interventions, you can see that not everyone responds in the same way to the same orthotic. Okay, so if we all gave you guys a 30-degree inverted orthotic and got you to run, what we'd find is some of you have big changes in peak rear foot eversion, some of you have little changes, and there'd be some really annoying person here that would actually have an increase in peak rear foot eversion for some strange reason. Okay, so what we tend to see is subject-specific changes, and they tend to be fairly small changes. If you move to the kinetics part of the paper, this is still the Mills systematic review, she's presented her kinetic findings in a table rather than forest plots, so it gets a little bit more cumbersome to follow. You can see that one of the studies by McLean using a posted moulded orthotic compared to a control, which the control, as I said, may have just been a flat insole like a sham. After the participants wore them for 6 weeks, there was a 20% change in impact force or eversion force. Okay, it's a force measurement. You can see the effect size on the right-hand side. So lots of non-significant findings here, and you guys would recognise the non-significant findings because of the confidence intervals. These all include 0 or cross 0. Okay, so we don't know much in terms of the effect of foot orthoses on lower limb kinetics, and if we know something, we know that they generally don't have a great deal of effect on moments. There's a few other findings here. I won't go through these individually. These are just for your reference, and to simplify this, I've summarised it at the end. But again, you can see these different types of features of orthoses, posted moulded to a posted orthotic that's not moulded, and then we've got non-posted, control, etc., etc., and there's some significant findings in here. Vertical impact, maximum loading rate. A more recent study published by Redmond, Carl Landorf and Anne-Marie Keenan compared contoured prefabricated foot orthoses to customised foot orthoses. And I've thrown this in because this was published after the systematic review, and there's some really nice pictures. I really like these pictures. Okay, so what we've got here is a whole heap of little cylinders, 3D cylinders that are indicating changes with the two types of foot orthoses. And, sorry, I'll just skip forward for a sec because we need a definition. There's our key. So the dotted cylinder is a customised and the clear cylinder is a prefabricated orthoses. So if I just go back to this one again, you can see in terms of peak pressure, both styles of foot orthoses tend to reduce peak pressure. So you can see, sorry, I didn't explain one other thing. You can see when the cylinder falls under the insole, there's a decrease. When the cylinder pops out the top of the insole, there's an increase. Okay? So you can see firstly with peak pressure, for most of the regions under the foot, there's a reduction in peak pressure with both styles of devices, but there's a slight increase around the lateral forefoot. Okay? Maximum pressure, there's a reduction in maximum pressure throughout the whole foot. Pressure time...
So is that comparing to no orthotic?
That's correct, yeah. Yep, that's comparing to no orthotic. Pressure time integral, we're seeing mostly reductions again. Maximum force, you can see that both styles tend to reduce maximum force under the heel, first MTP and under the hallux, but they increase maximum force under the lateral forefoot and under the midfoot. Okay? If we skip to the next picture here. Force time integral, a decrease under the first MTPJ, an increase in the arch. Pressure area, increased pressure area under the arch, decreases around the, well, first MTP. These are small increases. And then time, so contact time. Increases in contact time under the heel and midfoot and decreases contact time under the forefoot.
Sure.
Yeah?
That's not saying whether prefab or customised is good or bad. So you have to take those individual results and apply it to the individual foot.
Correct, yeah. And what we're seeing here is that they tend to be, the changes comparing the prefab and the more expensive and customised, customised orthotic tend to be comparable. You can see the cylinders are moving together. In nearly, probably 95% of cases, the cylinders directionally are moving in the same direction, and in terms of magnitude, they're of similar magnitude as well. Okay, so what this says is it doesn't matter if you just put a cheap prefabricated device under someone's foot or a customised device under someone's foot, you tend to get similar changes in plantar pressures. Okay, please don't be overwhelmed by these slides here with all these different types of plantar pressure measurements. I don't even understand them. I'm not a plantar pressures expert. My area is EMG. The key findings we'll summarise on the next couple of slides. So these are all so just going back, these were all the graphical presentations of the data. This is just all the data that you were just looking at. Okay, this is to put it into numbers so you can compare them. Again, you're not meant to be rote learning this or memorising numbers or changes. Okay, just take away the key points. Okay, so you can see all those changes. You can go through that in your own time and pick it apart. But generally what we can say is that foot orthoses decrease loading rate and vertical impact force when compared to a control and to a posted non-moulded orthoses. Okay, this is summarising from the Mills systematic review too, okay, that we're still on. We're still on the Mills systematic review as well. Increase in force and force time integrals in the midfoot region. There's a decreased peak and maximum mean pressure time and force time integral in medial and lateral forefoot. The plantar pressures, compared to the other ones that we've looked at, which is the kinetics, tend to lead to larger and more systematic changes. Okay, So when we compare it to motion of joints, the measurements associated with that, we tend to see larger and more systematic changes in plantar pressures than we do in joint motion. Okay, so this is what I was saying before. It's a nicer, cleaner area of research than the kinematics. In terms of the muscular effects, Catherine reported a couple of studies here, the Nowak-Zensky and Ludwig study and the Tamaro and Burdett study, and she found that the orthoses increased TA, tibialis anterior, and decreased bicep femoris muscle activity. Okay. My systematic review found that there's limited evidence that foot orthoses are associated with both a greater EMG amplitude for tibant and peroneus longus. Okay, now you'll notice that the summary I've presented on this slide here is slightly different to the previous slide from the Mills study. And the reason it's slightly different is because I included my own study in the systematic review and she excluded my honours study, which was published in Clinical Biomechanics, because I didn't report enough data for her to include it in the meta-analysis. So in my honours study in 2002, I found that foot orthoses increased tibant activity and increased peroneus longus EMG amplitude. Okay. Okay, so when you get to this end of the literature, you start asking yourself, as I asked you about 30 minutes ago, is this optimization in biomechanics, is this beneficial, or don't we know? And we don't really know. But one thing I tried to do as part of my PhD was I tried to work out whether changing muscle activity in a particular direction makes you function more normally. And what I mean by that is if you have a flat foot and we give you an orthotic, we put an orthotic under your foot and get you walking, does the orthotic make your muscles behave more like someone with a normal foot? And we thought, oh, well, at least we're making some effort to see if changing muscle activity in a particular direction is beneficial. Okay. So what I'm going to do in a moment, I'm going to present the key findings from my PhD related to foot orthoses and lower limb muscle activity. Okay. And that gives you some context about how foot orthoses alter biomechanics. I might just give you a couple of minutes break because there's a few people nodding off to sleep.